Bismillah ar-Rahman ar-Rahim. I am honored and pleased to present my dear friend, Professor Dr. Tamer EL-Sobky, one of the eminent of the pediatric orthopedic surgeon. Have many publications, many surgical procedures invented by his own trials. And I hope that the professional diploma limb reconstructive surgery, the graduation or the grade 10th, to be in time, and we will start discussion after the lecture to have a more benefit from the experience. I know that many questions will be raised all over the lecture, but please keep questions and comments. After the lecture, we will have another session of interactive discussion with Professor Tamer. Thank you for Professor Tamer again, and good luck for this afternoon. Inshallah, excellent and nice presentation. Fadl.
Bismillah ar-Rahman ar-Rahim. Today we are going to discuss a very important and clinically relevant topic. It's about the use of guided growth surgery for angular knee deformities in nutritional rickets. During this presentation, we will learn how to assess the skeletal manifestations of nutritional rickets and how to put the indications and clinical and radiological guidelines for their management. First of all, we have to mention that nutritional rickets is a global problem. It's prevalent in many parts of the world, especially in Asia and Africa, and which are low resource setting countries. So it's a disorder that you will frequently come across in pediatric orthopedic clinics or in general orthopedic clinics, and also in pediatric clinics. Of course, we all know that nutritional rickets is related to bad lifestyle, either insufficient dietary calcium or insufficient exposure to the ultraviolet rays of the sun, or both of them. Of course, we all know that rickets manifests in generalized bone deformities. It's not localized to any part of the skeleton. We are concerned here about the angular deformities around the knee, which are very common, and they can be very severe and can cause significant gait disturbances. These are clinical examples of the commonly of variants of the clinical presentation of rickets. This is a case we can see here, bilateral genovarum, or another case of unilateral genovalgum, and sometimes less frequently we see combined genovarum and genovalgum in the same patient. A deformity known as windswept deformity. Just for demonstration, this is the X-ray of the same patient. Just a quick review, we can see here on the right side, we can see a distal femoral varus, while on the left side, which has valgus, we can see an origin of femoral valgus. As you can see here by the arrow, there is a disturbed mechanical distal lateral femoral angle. And we can see here another contribution to the valgus in the proximal tibia, or the diaphyseal part of the tibia. Deformities in nutritional rickets, like coronal plane deformities, are usually associated with deformities in other planes. They are not simply coronal angular plane deformities or coronal plane deformities. The most classic example is the tibial varus or genovarum. They are usually associated with internal tibial torsion. And these torsional deformities, in addition to the angular deformities, they contribute greatly to the gait impairment that these children suffer. What about deformities in nutritional rickets? What is their fate? What is the natural history of deformities of nutritional rickets? They tend to heal spontaneously, unlike resistant rickets, which have genetic etiologies. They tend to heal spontaneously, possibly with medical treatment or sometimes without medical treatment by improving the lifestyle of the children. Yet, if rachitic activity heals, the deformity is still persistent. But what about the deformity? What is the fate of the deformity? Some deformities persist despite healing of the rachitic activities, and they continue to cause functional disability. These are examples of the various stages of rickets you will commonly see, and mostly you would have seen in your daily practice. For example, we have active rickets, demonstration of active rickets. Here is a classic example. You can see here around the epiphyses, around the knee and around the ankle. There is cupping. Cupping is mostly demonstrated here in the distal fibular and distal tibial metaphyses. And all over there is fraying and widening, and even resorption of some parts of the epiphysis itself, like the distal femoral epiphysis. This is a classic sign, classic radiological signs of active rickets. The other picture here, you can see almost more or less the same pathological changes, but to a lesser degree, lesser severity. But what is very characteristic is the white metaphyseal line. I hope you can clearly see it in the proximal tibia and the distal femur. This white metaphyseal line, sclerotic line, this is an indication that this patient is going into the healing phase and will eventually heal. As we said, rickets is a generalized skeletal disorder. So it's, if we are treating coronal plane deformities around the knee, we also have to be aware that other deformities may exist in the skeleton. And here is an example of active rickets of the wrist. And here the cupping is actually here more prominent. Here you can see it, and the same pathological findings as we have seen before. There is also, we have a demonstration here of active rickets of the hip. But as we said before, if you can notice here the metaphysis of the proximal femur, there is also a white line bilaterally. And this is also an indication that the patient is going, or indication of emerging healing. But having demonstrated this X-ray, we have to mention that we do not routinely X-ray the hips to screen radiological signs of rickets because of a fear of excessive radiation exposure to the genitals in children, but occasionally in some specific indications. To treat rachitic deformities in children, we have the option of osteotomies. Osteotomies are are long-honored technique to treat deformities in children, generally speaking. Traditionally, persistent long bone deformities in rachitic children and adolescents have been managed by corrective osteotomies. Corrective osteotomies have different designs and different approaches, and some of them may be fixed with various implants. Some of them may not be fixed, and they usually need a post-operative casting. And as we see here, this is a proximal tibial osteotomy. The results are fairly satisfactory here in this patient. But let's have a broader look into the treatment options of angular knee deformities in children, or here we are specifically talking about rachitic children. We have two main options. Either you do an osteotomy or either you go for guided growth surgery. But what are the fundamental differences between these two techniques? How can we weigh them or contrast them against each other? First of all, osteotomies achieve acute correction. When you go out of the operating room, then you should have achieved the intended correction, okay? While in guided growth, you implant your plate or whatever to achieve a temporary hemiepiphysiodesis, and then you go out of the operating room while the limb is still deformed, and you will expect gradual correction during follow-up. So this is acute correction in osteotomies and gradual correction in guided growth. Important differentiating point is in osteotomies, it is done through subperiosteal dissection. You osteotomize on bare bone after conducting a subperiosteal dissection. While in guided growth, which is a form of minimally invasive surgery, of course, the dissection is extraperiosteal. So you should respect the periosteum. So these are the main differences, and here is an example for a rachitic patient who has been subjected to a medial opening wedge osteotomy. Okay, another point, osteotomies versus guided growth. How can we weigh them against each other? Osteotomies are fraught with risks of complications. They are not complication-free, no matter how much experience you have with them. You can face over or under correction. That is commonly seen in osteotomies. You can face some sort of neurovascular insults, not necessarily with severe consequences, but you can face some sort of neurovascular insults and healing problems, especially depending on the type of wedge, if it's opening wedge, adolescence, and so on. So osteotomies, we have to bear in mind that osteotomies have complications. On the other hand, guided growth generally have a low complication rate and mild complication rate, or what's called tolerable complication rate. Another point is osteotomies require casting and immobilization. Because you have an osteotomy, you are waiting and supporting it and supporting the internal fixation, or supporting the position of the osteotomy with a cast till it heals soundly. While patients with guided growth are allowed to immediately wait there after surgery. This is just a demonstration or an example of overcorrection in osteotomies. You might get overcorrection. This is on the left-hand side, bilateral genovarum, mostly of tibial origin, and was corrected by a diaphyseal osteotomy. There is some sort of overcorrection. Sometimes overcorrection is accepted, it remodels or it doesn't affect function, but sometimes an overcorrection will need a redo operation. But we have to ask ourselves, why are rachitic deformities a management challenge? It could be that many physicians have an impression that rachitic deformities are more or less simple deformities, but that's really inaccurate assessment. If we take a deeper look into rachitic deformities, we find that they are actually complex deformities and pose a serious management challenge. Why are they complex deformities? Because they are not restricted to one bone. They are usually multi-osteotic or polyosteotic. In rachitic deformities, as we said, it's generalized skeletal disorder, so you will commonly find a femoral involvement and a tibial involvement, as you can see here in these radiographs, with various degrees of severity, of course. And another point is that these rachitic deformities can be multi-apical. if they are tibial deformities, you might, or femoral, you might find in the same bone more than one apex. And you can see with the yellow lines, this tibia has two apices. Generally speaking, if you detail, you can get more, but you have generally two major apices. Another point, another source of complexity in rachitic deformities is that they are multi-plane deformities. If you see a patient with genovalgum or genovarum, it's not really restricted to genovalgum angular plane deformities in that plane, but you might have also sagittal plane deformities. Like here, the radiograph on the right side, you have a sagittal plane deformity of the femur, and you can also get it in the tibia. So it's multiplanar, and it's multiplanar not only restricted to coronal plane, which is angular plane deformity, and sagittal plane, but there are also torsional deformities. Like we have said, the most common is the internal tibial torsion. So these are the three main sources of complexity that create complexity in the assessment and in the decision-taking and surgical management of rachitic deformities. But how does guided growth work? If we will choose guided growth and we find that it is some sort of less minimally invasive surgery and is more attractive than osteotomies in various grounds, how does it work? Simply speaking, it depends on temporary, of course, not permanent hemiepiphysiodesis. You can see here in the example of this tibial varus, we are arresting the growth of the lateral hemiside of the proximal tibial physis. So this can give an advantage to the medial hemiside of the same epiphysis to overgrow and take advantage and push the growth of the tibia unidirectional towards valgus. So the unarrested physis will overgrow in the direction of valgus till it gradually corrects the alignment of the limb. Okay? This is the main concept. But what are the indications of guided growth? In which type of patients and pathologies can we use guided growth? Actually, guided growth has become the gold standard for treatment of angular knee deformities in children. And it's used across a wide variety of pathologies, idiopathic, osteochondral dysplasias, which are also known as the bone dysplasias or genetic bone disease. These are a wide group of disorders, post-traumatic and resistant rickets, all, of course, with different success rates, but they are becoming the gold standard. Guided growth is also used to correct sagittal plane deformities. And the most evident example is correcting knee flexion deformity in cerebral palsy patients. Okay. Of course, this presentation is built upon our recent study, which is the first study to investigate the use of guided growth for angular knee deformities in a homogeneous series of nutritional rickets. Our study population is purely patients with nutritional rickets. But what are our aims from this study? We want to see the radiological and clinical results of the use of guided growth to correct angular deformities in patients with nutritional rickets. And we are targeting the young children. We also want to see if we correct the angular deformity of the tibial varus, for example. We want to see if the torsion of the tibia, the transverse plane deformity, does it correct simultaneously with the correction of the coronal plane deformity, or does it persist? That's the point we wanted to investigate. And finally, we wanted to conclude or come up with the roadmap or treatment algorithm that may help us and help others to guide decision making in angular deformities in general and in rickets in specific. This is our study material. You can simply click on any link here in the presentation and have more details about our published study. But how can we assess, or what are we supposed to assess clinically in these rachitic patients? Of course, history taking is for gait impairments is very important because we have placed gait impairments as one of the indications for intervention, and this is something relatively innovative, although it is subjective. We ask the parents. And we have also placed it as one of the outcome measures. So you have to ask the parents about any gait impairments. Of course, patients with genovalgum will have a circumduction gait, especially if severe and bilateral. To clear their knees, knees during a gait, they will have to circumduct, and that causes great difficulty in walking. Patients with an internal tibial torsion and genovarum will also have gait impairment manifested by frequent falls and many manifestations of gait difficulties. So this is something you have to ask the parents, and you will find that this is a very good indicator for the results of your medical, treatment, either medical or surgical. You will find that these deformities resolve or gait impairments go away and the gait parameters have improved. Anyway, you also have to see the child walking to assess for yourself the quality of gait. And as regards to torsional deformities, you can get an impression about the torsional deformities, of course, during gait, but they are more accurately assessed during couch examination. We also what do we also want to record clinically before to assess our rachitic patients? We want to see the degree of the angular deformity. We are treating angular deformities, but one of the things we want to record the degree, the severity. We can do that by measuring the clinical tibiofemoral angle. We also want to assess the origin of the coronal plane deformity. Is it femoral? Is it tibial? Or is it both? This is just an example of some of the clinical tools that are used to assess torsional deformities in children in general, and very useful to assess them, of course, in children with rickets. I really advise you to go and do some more extensive reading in the clinical assessment, because it's very valuable and very helpful in pediatric orthopedics assessment, deformity assessment in general. This is a patient here with massive internal tibial torsion as per foot-thigh angle. Just giving another example, this is a patient with bilateral genovalgum, adolescent patient, and during extended knee. But when we flex her knees, we find that the deformity has disappeared. This indicates that the deformity of femoral origin. But if it had not disappeared, it would have been of tibial origin. These are just examples of how can we get valuable clinical information about the deformities of the lower limbs in rachitic children. What about the scanograms? As we can see here, this is a full-length standing weight-bearing scanogram of the lower limb. How can this help us in decision-taking and assessing patients with deformities of the lower limb in general, or specifically here in rachitic children? In other words, what information can we extract from these scanograms that may be of value in decision-making or treating these patients? We can extract 3 or 4 basic points. First of all, you can assess the degree of coronal plane deformity. If there is a deviation or if it is normal, this can be done by the tibiofemoral angle or the mechanical axis deviation, and we will focus on this later on in the presentation. You can also know if the deformity is femoral or tibial or possibly combined. You can also detect from the scanograms where is the apex of the deformity inside this particular bone. In the tibia, is it diaphyseal, is it metaphyseal, and so on. You can also calculate if or record if it has one apex or if it has multiple apices inside the bone. Yeah. Okay, this is an example of mechanical axis deviation. Normally, the mechanical axis will pass by, or that is what we assumed because there are variations in what is normal in children. We assumed that the tibial metaphysis, the widest diameter, you can just slice it into 3/3. 3/3. Central 1/3, then a third lateral, and a third medial to it. We assume that if the mechanical axis does not pass through the central 1/3, then this is abnormal. This is a deviation. And we can see here that, of course, the mechanical axis is passing not only in the medial 1/3, but it's outside the tibial condyle. So medial mechanical axis deviation to the central 1/3 is actually a varus malalignment, while lateral to the central 1/3, as we can see here, is a valgus malalignment. And you can see here various degrees of severity of valgus malalignment. One is on the right-hand side, closer to the text. You can see that this is a mild mechanical axis deviation, while on the left-hand side, that is a severe mechanical axis deviation. Okay, but this is to assess the quality, if it's a varus mechanical axis deviation or if it's a valgus mechanical axis deviation. What about the severity? How severe it is? How can we measure severity? To measure severity, we graded the diameter of the tibial epiphysis, if you can see here, and we will take 1/2 of it. This is a relative method. It's better to use a relative method than an absolute method. We will not measure in centimeters the deviation, but we will measure it as a percentage in relation to the half the width of the tibial epiphysis of the same patient. So every patient has his tibial epiphysis, half the width is his reference. We cannot measure in centimeters because the configuration and the width of the epiphysis and metaphysis is quite different from according to different children, even if they are the same age. So it's better to have the reference inside related to the same patient. So half the width of the epiphysis is 100%. If you have a deviation that is amounting to 2/2 the width, then this is 200%, and so on till you reach 400%. We graded them into 4 zones, and this has actually been proposed by other researchers in the literature, and this is actually more accurate, as we said, than absolute measurements. Here, this is an example. If you can see here, I will give more details later. The central 1/3, both of them are away from the central 1/3. But the knee on the right-hand side, the mechanical axis is passing outside the central 1/3, but still in the condyles of the tibia. So this is zone 1. But on the left-hand side, we can get him almost to in an area or in a zone that is almost 3 times the half the width of the tibial epiphysis. So this is zone 3. Here is another example of varus mechanical axis deviation. As we said, the mechanical axis is falling medial to the knee or medial to the central 1/3. There is a difference between them. It's more important to know the concept. You can measure later. One is zone 2 and one is zone 3 on the margin. Yeah. Another point that I saw is very clinically relevant, and many physicians are confused about it, and it's very critical to assessment and to decision taking. What are the similarities and dissimilarities between rickets and Blount disease? Of course, here we are talking about infantile Blounts and rachitic children, young rachitic children. It may be somewhat confusing. Is he rickets or is he Blount disease? Because this has implications to many things in treatment, medical or surgical. First of all, in Blount disease, you have to know that the deformity is epiphysiometaphyseal of the medial part or postomedial part. So it's epiphyseal or subphyseal in the metaphysis. So it has one apex or one location. So in contrast, the rachitic deformities can be anywhere along the tibia or the femur, and inside the same bone, they can have multiple APCs. You see here in this patient, he has a mid-diaphyseal tibial deformity. This should not be present classically in Blount disease, unless he has also a rachitic deformity. And as we said, it can be, he can have multiple foci of deformity in other bones. A metaphyseal diaphyseal angle, and as you can see here, you can do further reading, but here it is well demonstrated here. Angle that is greater than 20% is almost pathognomonic of Blount disease. Patients with rickets have an abnormal metaphyseal diaphyseal angle, but they measure less than 20 degrees. Less than 20 degrees. So the cutoff value is possibly 20 degrees. Laboratory markers are important because if the alkaline phosphatase is elevated, and of course, if you have rachitic changes on X-ray, so that is an indicator that the patient has is rachitic and not Blount. Sagittal plane deformities, as we have said, can occur in rickets, especially in away from the proximal tibia, in the distal tibia of the fibula and tibia. So that is an indicator of rickets, and this does not classically occur with Blount. The most important piece of information in differentiating between rickets and Blount disease is that nutritional rickets and infantile Blount disease could co-occur, and they actually usually it is not a rare encounter to find both deformities in the same patient. So you have to be aware that you might be treating these two pathologies. Okay, when to intervene surgically in rachitic children? Actually, this point is not clarified at all in the literature. There are no clear indications for surgical intervention, or in other words, what do we specifically mean if we want to go make a little bit more focus on this point? We are unaware of which deformities healed rickets, yeah, but persistent deformities. Which deformities are likely to resolve spontaneously and therefore not need surgical intervention, and which deformities are likely to persist into adolescence and so on and affect the gait, and so this will likely need surgical deformities. we have no clear answers for these questions. Actually, there are many co-variables that are known to affect the prognosis or the resolution of these long bone rachitic deformities, but it's not known for sure how do they affect the prognosis. We need more studies to actually extract how do these factors affect the prognosis and help us in decision taking. And these factors are age. Age is actually very important. Possibly the rachitic children at a younger age behave differently from the young children from old children. Varus versus valgus. It is postulated that this may have an impact on prognosis. Valgus, for example, may behave differently from varus. Unilateral deformities may behave differently or respond differently than bilateral deformities. Deformity severity, severe deformity versus mild deformities. These are all factors that interplay, but it's not known for sure how can we use them precisely to take decisions, medical versus surgical treatment. Okay, we have proposed some criteria for surgery. They are a mixture of radiological and clinical data. First of all, these criteria are built on or based or assume that the patient is a healed rickets. Of course, that's something you have to make sure of. The patient is healed. You cannot operate on patients with active rickets. And his deformity is either worsening or at least persistent over the 6 months prior to your decision. So healed, persistent or worsening deformity of healed, persistent or worsening deformity over the last 6 months. So we have to give a chance to the patient and see, make sure that his deformity is not improving or not resolving. And here we have set an overall valgus or varus more than 20 degrees as per femoral angle. And we have also here used the mechanical axis. As you can see in the picture, this is the central 1/3 we are talking about. A mechanical axis that is passing through the central 1/3 is our target. And we cannot intervene in such a situation. But if it passes to the medial 1/3 or the lateral 1/3, then this is marked here by the two different colors, and this is considered a mechanical axis deviation. Okay, we have introduced also the symptomatic gait abnormalities, because symptomatic gait abnormalities can be disabling to patients, and we should ask parents and targeted questions to reflect the gait abnormalities that their child is suffering, and you should also see patients observe them clinically. Okay. We want to put forward some general technical principles of guided growth. So, as we said, you should be very careful about the periosteum. Keep the periosteum intact. Your dissection should be strictly extra-periosteum. When you operate, you should insert the epiphyseal screw first and make sure it is you are satisfied with it. Then you have the flexibility to insert the metaphyseal screw, but otherwise may cause problems. You should avoid violating the articular cartilage and the physeal plate. This is ultra important. Otherwise, you will cause more damage than benefit. So, screw parallelism, as we have demonstrated here in this example, yes, it's advisable. And in the other example, we have demonstrated here a placement of the screws in the mid-sagittal or mid-lateral plane. It's advisable, but it's not mandatory. It's not a must. If you can achieve it with minimal or one attempt, it's okay, it's fine. That's what we should aim at. But if it is not achievable, then you should not do multiple drilling attempts that may compromise the screw and may give rise to potential risk for injury of the growth plate in order to achieve these goals. Because the most important thing, again, is to avoid injury of the growth plate or the articular cartilage in both AP and lateral. That should be the baseline. If you can achieve parallelity and mid-sagittal plane alignment, nicely aligned, okay. If not, do not fight too much to achieve this, because this mostly does not impact your result. Use of longer screws is permissible and actually advisable. There has been, at the beginning of the guided growth, there has been some concerns about using very long screws and passing the midpoint of the bone. No, it's really advisable because it gives a greater strength and could decrease the incidence of loosening, and it will not really affect the growth of the other side and has no a negative implication, so long you do not violate the far cortex. And we advise you to use a tourniquet because it can reduce the operative time fundamentally. These are some tips. Of course, the plate of the guided growth is actually pre-bent, but you might need to bend it more according on the local anatomy you have. You are working on deformed bones in the distal femur or in the proximal tibia, and not each patient is like, all patients are not really similar. So you might need to adapt it to your local anatomy. And you might need also to choose a different size. There are small, medium, and large. It depends upon the age of the patient. So be aware of this, because if you use a standard one, if you use a small one in a big, a relatively big distal femur, then you might really face technical difficulties and induce and have consequences. Yeah. A very important tip is to drill only the few millimeters of the screw track. As you can see here in the X-ray, do not drill the whole length to the whole length of the inserted screw. No, it's enough to drill a few millimeters, and then you go into the track, and by your clinical sense, guided by X-ray on demand, you can go through your track. This helps the screw purchase. And you are actually, you should be aware you are working in cancellous bone, relatively soft bone. You don't need really to drill all through. That will compromise the purchase of the screw. Yeah. Assessing the outcomes of surgery, again, I have put the demonstration of the 3 zones that we have used to assess patients, assess to propose the indications, assess the severity of deformity, and we will also use them to assess the outcomes. As you can see here, the yellow arrow is the central 1/3, and the others, the green and the red, are actually represent the mechanical axis deviation. If the mechanical axis does not fall in the central 1/3, then this is a deviation. How are we going to assess the outcomes of surgery? Is it successful or not? We have multiple parameters. Of course, we want, our target is to restore the mechanical axis. If it's deviated medial or lateral, we want to restore it to the central 1/3. Or the equivalent is the clinical or radiological TB femoral angle. We want to normalize this angle. And they more or less go parallel. If you normalize the TB femoral angle, then actually you will normalize or restore the deviation of the mechanical axis. It's just two different ways to measure it. As we said, we have introduced the as one of the indications of intervention and one of the outcome measures to assess the outcome of surgery is the gait difficulties. It's very important to ask parents before, as we said, before and after surgeries. And you will find many parents even initiating this discussion that they have observed that their gait difficulties have resolved after surgery. So it's not only anatomy and alignment and disfigurement that has resolved. No, it will reflect on function. And then we, for this specific point, to see the tibial derotation, we have used the bimalleolar axis, which is a clinical measure. This is a little bit more detailed. You can find, if you read the article, you will find even more details on this, a little bit refinement of the outcome measures. As we said here, now forget about the colors of the previous slide so that we don't confuse you. This is the central 1/3. So our target is to get, as we said, the mechanical axis into the central 1/3. This is okay. This is our target. This is success. Okay, one of the measures of success. But we have further subcategorized it. The yellow represents the medial half of the central 1/3, which is, as we said, our aim. And the green represents the lateral half of the central 1/3, and it is still our aim and our target. But we have said, if the mechanical axis falls into the medial half, into the yellow zone, medial half of central 1/3, we will say that this is accepted. But if it falls into the lateral half of the central 1/3, we will say that this is optimal, because valgus is more physiological than varus. Usually in children, we don't have a fixed point to say this is normal or not, because children have dynamic growth and are always changing and evolving their biomechanics through the various stages of growth. So this is accepted versus optimal. It's an attempt to grade or improve results, but it's not really basic here. As we said again, to avoid confusion, get the mechanical axis into the central 1/3. This is okay. This is a little bit more detailed classification. Yeah. When to remove implants. In a clinical setting, you're not doing research. Plates can be removed based on the clinical judgment of the physician, or the clinical, in other terms, the tibiofemoral angle. Of course, by couch, and of course, during weight bearing, because there may be an element of soft tissue laxity that may affect the ankle. If you are satisfied with it, then this could be okay, because many patients and many locations do not have the availability to do a scanogram. But in a research setting like our study, they can be removed based on both restoration of clinical and radiographic parameters. We want to draw attention to certain points that may be overlooked or underestimated. Of course, you are all minded with what we said during implantation of your plate or staple or whatever. Avoid injuring the periosteum. This is not the whole story. This is important. But what is even equally important, that when you remove your plates, you should be aware not to damage the periosteum. You should be equally cautious not to damage the periosteum. Plate removals may be, plate and screw removals may be more difficult than inserting them. You are working on a disturbed anatomy. There is usually plates and screws, when they are retained for a long time in the patient, they are covered by deep fibrous membranes and are really hidden, and you might do excessive, vigorous trauma that might injure the periosteum during removal. So you should be equally cautious. Be aware also of recurrence of rickets. As we said, absolute prerequisite, you cannot operate on patients, whatever the indication is, unless they have healed rickets. When you operate on them and you follow up their deformity, gradual correction, beware that even if they were healed at the first, before the beginning of surgery, at the start point of surgery, they can develop recurrence during this lengthy treatment period. So it's very important to keep an eye on recurrence of activity, because if rickets activity recurs, the deformity may recur and actually compromise what you have been doing. The results of gastric growth, shortly said, the overall clinical results were really satisfactory. The complications were tolerable. They did not affect the consequences of surgery and the outcomes of surgery, and they were mostly related to screw loosening and implant disassembly. And we realized that this occurs in patients who have severe deformities. So in consequence, the plates and screws have to be inside for a longer time, and that gives rise to complications, or is a precursor for complications that may need some measures and may delay the timing for correction. And you can see that in the treatment algorithm in our article. Yeah. This is an example of a clinical assessment of knee alignment. A patient with left genovalgum, you can see him 6 months after 9 months. Okay, this is fine. If you see this is fine, I can remove the screws without a scanogram. You can do x-rays if they're available to check certain things, or in certain localized indications if you have really a tibial only deformity or whatever. But generally speaking, I do not need a scanogram in a clinical setting, but in a research setting, as we said, we might need to be more precise. Follow your patients closely, at least every 3 months, and that's something you can negotiate with the patients, and depending on the clinical setting and severity of deformity he has, you don't have to x-ray them every time they come. If there is available x-ray, then it can be used before you remove, when you are attempting to remove the plates. This is another patient here, clinical assessment of bilateral knee alignment, severe deformity. This patient had her screws retained for a very long time because she had a severe deformity and the screws suffered the displacement, and they lost their full ability to provide epiphysiodesis. We had to leave her for a very long time till she corrects. And in other situations, we had to intervene. And that's why we proposed treatment measures. We proposed a new treatment method, tactics to resolve this issue. You will find it in the treatment algorithm. This is the same patient here. You can see her mechanical axis, and you can grade it according to the different severities we have mentioned. And she is fully normalized. Here you can see that she is passing in the central 1/3, almost in between the lateral and medial half. She is, her mechanical axis is fully restored. Another case with unilateral genovalgum, and this is the final post-operative. It's very important to follow up patients. The x-rays, the clinical photos we are presenting here are, most of them are the clinical photos at the final follow-up. When you remove the implants and you are satisfied with the alignment, that's not the end of the story. You have to follow the patients for a longer time to first of all, as we said, to exclude any recurrence or detect it early, or to exclude a rebound phenomena that has been reported in the literature. You have to make sure that patients are still keep maintaining this alignment. This is another patient with genovalgum. You can see here, of course, it's evident on the left side, she has severe genovalgum. On the right side, she has mild genovalgum. We will see it later on radiology. Actually, we operated, this is finally, we operated only on the right side. We left the left side, it was mild. And as you can see here, both have been corrected. The one on the right side remodeled, and the left side responded to surgery, the severe one. And as we see here, she has mild mechanical axis deviation on the right, but severe on the left. And you can see here, both are restored. The one on the right remodeled, while the one on the left was managed surgically. So it's a matter of clinical judgment, and the proposed criteria are just to guide you or to help you take decision. What are the complications? As we said, they are mostly tolerable complications. And most complications were related to failure of guided growth. Failure means subsidence of the screws or disassembly of the screws or whatever, anything related to implants. Most of them either necessitated a redo surgery. We did redo of guided growth, and that has some, and there were varieties of the redo in guided growth. Or simply observe the patient till full correction if she is correcting, if the patient is correcting after time, but the drawback is that you will wait for a longer time. Okay, this is simply examples. This is a very rare complication, at least in our series. This has mostly been related to Blount disease, and that is screw breakage. Screw breakage is different from screw subsidence. We had only one patient in our series, and actually the characteristics of screw breakage in the literature actually coincide with this screw breakage. Screw breakage, for whatever reasons, are almost exclusively metaphyseal and not at the screw head and the head of the screw, but at the junction of the cortex and the shaft of the screw. And that's typical to the literature. We got the same finding here. This has to be redone. This is an example of redo of guided growth. This is another patient here, implant disassembly. You can see here the implants are fully, completely disassembled in the, especially on the right, where the distal femur and the proximal tibia have been epiphyseal. But see, despite we have attacked both physes, but he had very severe deformity, and this is what is likely to happen in severe deformities. Actually, this patient was lucky enough to to correct by himself, but he took a longer time. Okay. Okay, we were going to sum up now. The results expand the range of pathology in which guided growth can be used effectively. So nutritional rickets are, angular deformities in nutritional rickets are responsive to guided growth and have a low complication profile, and it is a really effective procedure. Concerning the derotation, we have experimental studies. It's not my study, but you can click on it and read the details. It's on an animal model. And it concludes that rotational deformities in long bones like the femur can be managed by guided growth, by orienting the plate in certain direction, and then it can eventually lead to gradual correction of the rotational deformity. But this was on a rabbit model. The current study demonstrated that tibial rotation occurs simultaneously with correction of coronal plane deformities by guided growth. So that's an important piece of information. Yeah, The conclusions from our study can be generalizable because we have a homogeneous and pure sample, so we can generalize them to young patients with nutritional rickets. Tibial derotation simultaneously occurs with coronary plane deformities, and we do not really need a derotation osteotomy to correct the tibial torsion. We needed it. We did resort to it only in one patient. Otherwise, we found that all patients with severe internal tibial torsion and varus, when we corrected the varus by guided growth, they derotated simultaneously. So we do not really need derotation osteotomy in classic beings. The outcome measures and the treatment algorithm can be used to plan surgery for other coronary plane deformities in non-rachitic in children or in other etiologies. They can be a general guide, deformity-wise or mechanical-wise. What do we recommend? We recommend natural history studies, because natural history studies will tell us which patients really are more likely to resolve and which patients are more likely to have persistent deformities and need surgery, so we can base our surgeries in a more informed decision. We thank you very much, and I'm always ready to accept any questions. Thank you so much.